Good afternoon, and welcome to the Families USA webinar, Medicaid Waivers, Work Requirements, and Beyond. I'm Patrick Willard, the Senior Director for Partnerships and Consumer Engagement, and I want to welcome you to our webinar today. We'll be joined by Dee Mahan, who is our Director of Medicaid Initiatives, and Elliot Fishman, our Senior Director for Health Policy, on today's webinar. We've seen a number of Trump administration initiatives to require and embrace work requirements in states. Just recently, in fact this month, the Trump administration approved a waiver for the state of Kentucky that included work requirements. We know that CMS is also currently reviewing work requirements for both expansion and non-expansion states. Here you can see the number of states that are looking at the 1115 waivers at this time. Some of those states are expansion states that are looking at adding a work requirement to them. Some are non-expansion states that are looking at having a work requirement for their existing. We also know that there are some states where legislatures are considering expanding, going ahead with the Medicaid expansion and expanding with work requirements. As you may know, there are 18 states now that have not yet expanded Medicaid. And so in some of those states, we may be seeing work requirement legislation moving forward. That's why we wanted to talk to you today about what state advocates can do in their work on these waivers, and think about how we can build a message that can be used not only on the state level with these Medicaid waivers, but also for the longer-term fight, which we know will be coming when the issue of work requirements comes before Congress. That's a place where we have seen the discussion about work requirements in last year's efforts to repeal and replace the Affordable Care Act, and we expect that it is an issue that will continue to arise. So today we want to provide you with some information about how states can talk about work requirements within their own states as the waiver process is moving forward, and then also talk about some other restrictions that could come up as part of the waiver conversation. In today's webinar, we'll have the presentations first by Dee and then by Elliot, and then we'll be taking questions. If you have questions, please type them into the chat box. We'll be using the chat box as the place for questions and answering them from here. But we won't be taking any questions over the phone for today's webinar. The other thing that we know is that many of you are interested in messaging around these work requirements. Work requirements have proven to be very popular with the public, and we have seen that popularity in polls conducted by the Kaiser Foundation that shows that it is not only popular with Republicans but also with the majority of Democrats. We understand that there need to be efforts to work on our messaging, and we know that a number of groups are doing polling right now and addressing focus groups right now to try and develop messaging that will help state advocates in their waivers. We want to talk a little bit about some ways that you can frame these conversations so that it becomes clear that what we're talking about in the case of work requirements is a problem that is going to stand in the way of people's job opportunities. That when we really come down to it, what people are looking for are job opportunities and better opportunities. And work requirements will take away those job opportunities in the end. So we'll be talking about this and other ways you can think about the conversation about work requirements. At this point, I'm going to turn it over to Dee Mahan, our Director of Medicaid Initiatives, to talk a little bit about how states can work in this area. Dee?
Okay, thank you, Patrick. And if you can just, yeah, great. First, I think it's helpful to keep in mind how what's happening with waivers fits into a larger agenda. And we saw that agenda over the summer with the Republicans' failed legislative attempts to end the ACA, end the Medicaid expansion, and remake the Medicaid program. The aim is to greatly shrink public programs, and having lost the legislative fight, this administration is trying to use other channels to do the same thing. So we're seeing that with the ACA sabotage, cutting enrollment periods. With Medicaid, it's trying to remake the program through waivers. Work requirements, timeframes, drug testing, lockouts, these are all things that we're seeing in waivers, and we're going to talk a little bit more about those later on. But they're not about expanding coverage. They're not about improving people's lives. They're not about making people more independent. They're about making Medicaid less secure, less reliable for enrollees, with the goal of eroding public support and making the program easier to cut. This really is a fight about how to define Medicaid, who the program serves, and the government's role. That's something I'd ask you to keep in mind because, as Patrick alluded to, a lot of you we know are in states that haven't expanded Medicaid yet, you're hearing from governors or legislators that are asking support for work requirements as a deal to expand coverage. It's a tough spot to be in, but as you evaluate what to do, and you have to do what's right for your state, please do keep in mind the political endgame. The more states that have work requirements through waivers, the easier it's going to be to pass them through Congress. And ultimately, your state Medicaid program is only as strong as the federal program. So you might be trading a temporary step forward for a longer-term step backwards. From the perspective of the right, the trend in public opinion makes it imperative to cut Medicaid now. A poll taken about a year ago found the percent of people who think that the government has a role in ensuring health care coverage for Americans is at the highest it's been in decades. That's because of the ACA and the Medicaid expansion and all of the work that you've done. But it's also a trend that Republicans really need to push back if they want to cut the programs. And that if it doesn't get turned back, that's going to be harder to cut Medicaid later on down the line. There's also a lot of support for Medicaid in general, with 74% of people viewing it favorably. And let's be honest, it's hard to get 74% of people to think favorably about anything pretty much. So public support's also shown itself in the polls, with the recent Maine ballot initiative on expanding Medicaid winning by nearly 20 percentage point margin. Our job is not just to keep the Medicaid program strong, but keep the public support for Medicaid strong and the idea that everyone should have health coverage strong too. And that's the context that I want to look at work requirements. First, remember that there's a lot of data out there showing that most people on Medicaid do work and most who don't can't. So with just the facts, here are what the programs are looking like that we're seeing states ask for. They include a work requirement with minimum hours. Certain groups are usually exempt, people with disabilities, medically frail, certain caregivers and students. Volunteer work and job search time can count. People who don't meet the requirement are generally locked out, and a lot of states are coupling this with hard time limits for Medicaid eligibility for all adults. In waiver applications, this is all couched as connecting people to work and building independence. And as Patrick said, these programs often poll well. But what we should be clear on is that these are programs that are not about helping people get jobs. We are all for programs that really do help people get jobs. That's not what this is. This is not about connecting people to work. It's about taking away their health care coverage. And the proposals that we're seeing are not coupled with people gaining coverage through expansions. In a lot of them, people can't meet the work requirements and still stay on Medicaid. So do the math. See how these programs are really going to affect people. And then also step back and try to reframe the conversation. It's important to keep pointing out that most people on Medicaid who can work do, but also try to shift the focus. You want people to get connected to jobs, but taking away their health care coverage isn't how you do that. So start talking about what really creates job opportunities and ask tough questions. How is taking people's health care away going to create long-term work opportunities? How's that going to bring employers to communities? How is this going to spur economic development? Ask how cutting people off health coverage is supposed to help them work, because there are studies showing that Medicaid actually helps people get healthy so they can get and keep a job. And demand to know how. If the response is, oh, it will, don't accept that. It's easy to say something's going to work, but ask for the details. Ask for the studies showing how it's going to work. And then ask tough questions about volunteer opportunities as well. And excuse me, I'm having a lot of problems with having dry air here. But anyway, ask tough questions about volunteer opportunities as well, because the volunteer work is asking people to work for free. It's usually couched in terms of community engagement, but these are things that are going to have real consequences on job markets. How is an influx of people willing to work for free going to depress wages and benefits? What's the impact going to be? This could threaten paid workers, hurt labor markets. Ask how the state's going to make sure that doesn't happen, and point out that insurance coverage isn't wages. It isn't any money going to workers. It pays doctors. It isn't helping Medicaid enrollees gain independence. Ask what happened to the idea of a minimum wage and paying people for the work that they do. And then there are unintended consequences. How are you going to make sure that people who can't work don't? This is really about amount of paperwork for people. There are a lot of people who aren't going to be subject to the work requirements because they're sick, they're retired, and they're students, but they're going to have to document what they're doing, and they're going to get caught in this and end up losing coverage. How are people who are going to be retired going to be justifying that they're not working? How is this going to be implemented? There is amount of paperwork also for people who are working right now, paperwork that employers are going to have to fill out. How is this going to work for people who work multiple jobs, small jobs? What's going to count as hours worked? As for the details, and point out that this is about building a bureaucracy. It's not about small government. It's about putting roadblocks in the way of people getting health care coverage. This slide shows how the waiver process goes sequentially, starting at the state level, either through legislation or through the executive branch. And then states have opportunities. There's going to be a state comment period for 1115 waivers, a federal comment period after waiver approval, further comment, further hearings, and then evaluation. There are a lot of opportunities within this for advocates to get engaged. And we suggest that you start getting engaged early and start at the state level as soon as you can. And with this administration, your best opportunity to get something changed is going to be at the state level. So before there's a waiver proposal, take every opportunity to highlight how important Medicaid is. Tell personal stories, talk about the benefits it has, talk about how it's helping people keep a job, stay healthy so they can work. And start getting ready for the fight when the waiver proposal hits, building your coalitions early and getting your talking points and stories in order. And as soon as waivers are mentioned, start advocating. Contact advocates in other states who've gone through this and see what's worked. And try to get changes made in the legislation or in the waiver proposal before it's out for public comment, because that's the easiest opportunity that you're going to have to change something. It's harder for a state to walk back on something after it's already out there. When the waiver does go public, though, it is important to engage people in the comment process. 1115 waivers have a formal state comment period, and 2 hearings are required. Use those opportunities to get as many comments as you can, get the press to come to hearings, get people to stand up, ask tough questions, and tell their stories. Once the waiver goes to CMS, use the opportunity to file comments. Even if you think you're not going to get anything changed, the number of comments helps build a record, and that can help in litigation, and we're going to talk about that in just a second. So take advantage of that, and also bear in mind, after the waiver goes live, things can change. Keep advocating. You can help make the waiver process better in your state through the way it's implemented, but also I like to remind people what's passed in a waiver doesn't stay that way all the time. You can work with the state to have it changed, and Pennsylvania actually changed from a Medicaid expansion with a waiver to a straight expansion. So there are opportunities to do a lot after this comes live if it does happen in your state. And finally, Families USA has a waiver resource center that's there for you on our website, and we hope that you guys use that. And if you are using it, please let us know if there are any ways we can make it better so that it can work for you better.
Thanks so much, Dee. And now we will go to Elliot Fishman, the Senior Director for Health Policy, to talk about the waivers and some additional problems besides work requirements that are out there. Elliot?
Thank you, Patrick. So the title of today's webinar was Work Requirements and Beyond, and I am the and beyond portion. I'm going to try to talk about the universe of problematic waivers that are currently under consideration. A number of them were approved in Kentucky, not just work requirements. And my overall point is to call attention to that very concrete and I think really irrefutable evidence that, as Dee described, the issue of work requirements is the political ground on which people who have broader issues with the Medicaid program's coverage of low-income adults have chosen to fight. But they are going after that coverage in really a multitude of ways, and it's important that we as advocates are sophisticated about that and do not fall for what I think is really a rhetorical and political danger of only talking about the work requirements issue. So first I wanted to talk about the big picture of how the Trump administration's attitude towards Medicaid waivers has evolved, and then how it's going to get litigated out. And it can now be definitive. The litigation has been filed in Kentucky. So where before we had to be a little hedgy with regard to litigation, it's now certain that litigation is happening in Kentucky and continues to be a near certainty in the other states that we've been talking about. So in terms of the Trump administration's principles, the initial principle that the Trump administration announced, starting with a letter shortly after Seema Verma and Tom Price were appointed, was described in 1A and 2, which is a lot of deference to states in terms of beneficiary protections. It's not really our place to tell a state what to do, but when it comes to money, then it's our place to tell a state what to do. That was the basic principle, and that extended to Medicaid expansion itself, which, as we all remember, the Obama administration clearly supported, and the Trump administration was going to be agnostic. Well, those of you who have followed the story of repeal and replace legislation know that the Trump administration's agnosticism with regard to Medicaid expansion didn't last very long, and that anti-expansion rhetoric has really persisted through the National Association of Medicaid Directors Conference in the beginning of November and on an ongoing basis. Seema Verma at the conference gave a widely publicized speech in which she directly described the coverage of non-elderly adults without disabilities as a mistake in the Medicaid program. So essentially stating an anti-expansion view. I think that's going to be very important both in our collective advocacy and ultimately in litigation. So with regard to litigation, the first statement here that waiver approvals are subject to judicial review, that is very important. The authority to waive the Medicaid statute is broad, but by no means unlimited, and it is specifically tied to promoting the objectives of the Medicaid program. And there have been waivers that courts have enjoined and overturned historically. There's not a lot of precedent around Medicaid waivers specifically, and it is telling why there is not a lot of precedent around Medicaid waivers specifically, which is Medicaid waivers have generally been used to expand coverage. There's very little precedent around using waivers to take coverage away, and therefore there's very little litigation about what seems to be a blatant violation of the statutory limits around the Medicaid waiver authority. One reason for optimism is that the federal courts, as I'm sure we've all been following in areas like immigration, in areas like voting rights, has been prepared not only to block the administration's actions, but to question the administration's stated motives. That's going to be very important when it comes to the litigation around these Medicaid waivers, because the framing that the administration is trying to put on them is that they promote health. And a critical question for the courts is how much deference to give that framing. So this is the basics of the statutory limits on the Medicaid waiver authority. It lives in Section 1115 of the Social Security Act. Many of you know that Section 1115 is not where the rest of the Medicaid program lives. It's Medicaid program is Title 19. 1115 authority, in theory, covers multiple programs in the Social Security Act. It's been used by far the most for Medicaid. It requires that Medicaid 1115 waivers be a demonstration, something really to call attention to at this time, right? The actual title of Section 1115 refers to demonstrations, and that one of the important arguments to be made in a litigation context is that the intent of a section talking about demonstration authority is not to make wholesale national changes in one fell swoop across the United States, particularly changes that Congress just failed to pass in the repeal and replace legislative battle. So I'll start with a bit on work and community engagement requirements. Dee just did a deep dive on those, so I don't think we need to spend a lot of time on the programmatic details. What I want to call attention to here is how many non-expansion states are on this list. And to the extent there are expansion states on this list, it is being pursued by a governor who was not the original governor who pursued Medicaid expansion. The question that, for example, appeared on the front page of the Washington Post a couple of days ago of balancing the possibility of a non-expansion state expanding with a work requirement, which Dee spoke about, it's really telling and important that no one has called that question yet, right? There is an asterisk next to North Carolina. They've submitted a waiver proposal which has kind of a placeholder for expansion with a work requirement. There are no details around it. They don't have legislative authorization. We'll see if they are the first one to call that question. But this is in and of itself an important piece of evidence that work requirements are just a convenient way to attack Medicaid coverage of adults for states that oppose Medicaid coverage of adults as laid out in the ACA. In terms of the legal issues, so these I think I've talked through, but I do want to call attention to the last bullet on this slide. Many of us on the phone have lived through a gradual process of simplifying the Medicaid eligibility determination process that really culminated in the Affordable Care Act and the new regulations that implemented the Affordable Care Act's requirements around eligibility determinations. A really important aspect of these requirements that Dee described is that they are taking us backward, really taking us backward decades in terms of documentation requirements, and the whole history of the Medicaid program shows that lose at least as many people who actually qualify as eligible under whatever they're supposed to be documenting as people who are not eligible every time you add new documentation requirements. The next, and I think really scary waiver to describe is one that was just approved in Kentucky, so will be part of the legal challenge in Kentucky, and is likely imminently going to be approved in Indiana, and then potentially in Maine and New Mexico, although the timing on those is less clear, would impose lockouts both for failure to pay premiums and this is a really disturbing new waiver authority, for people who fail to renew eligibility. Important points to remember when countering this kind of an idea is that unlike marketplace coverage, which yes has an open enrollment period, but it's very important that people who already have marketplace coverage auto-renew. There was a moment when there was a flurry of rumors that the Trump administration was going to pull back on auto-renewal. It didn't happen. So Medicaid is really the only kind of insurance that requires annual eligibility redeterminations. People, even with the simplifications under the Affordable Care Act, people generally 25% or more, depending on how much the state has simplified redeterminations, of people lose eligibility at redetermination, and then the great majority of them come right back on shortly thereafter, because it's not that they lost their underlying income eligibility or moved out of state. It's because they did not get the renewal paperwork, or they, like any of us would, if we had to annually recertify our health insurance eligibility every year, they didn't get around to it. They have busy lives. What Kentucky has approved is that their Medicaid adult population will lose coverage for 6 months. They'll be locked out of reapplying. So the turning off and turning on phenomenon will be disrupted in Kentucky. This is just incredibly scary in terms of math, right? And especially combined with a bunch of new documentation requirements. I'm just worried that hundreds of thousands of people could lose coverage from this alone. Premiums as a condition of eligibility. So the Obama administration crossed one line in terms of waiver approvals, starting in Iowa, which allowed for premiums to be a condition of eligibility for people above poverty, allowed premiums to be billed to people below poverty, but not to be a condition of eligibility. They could either go into collections, or in Indiana, there was a choice of coverage levels that was tied to premiums. The thinking was that people below poverty, by definition, do not have disposable income to spend on Medicaid premiums. That's what poverty means. So that was why that line was drawn. That line is now breached in the Kentucky approval, and there are additional approvals which are likely to breach that line. Additional proposals, excuse me. Waivers of the early periodic diagnostic and treatment benefit, the core benefit for children in Medicaid. It's not unprecedented for there to be waivers of EPSDT, but it has been extremely rare, and we ought to be concerned about the precedent. Utah and New Mexico have proposed to waive EPSDT for 19 and 20-year-olds. And note that there is a sound, in addition to the precedential concern about once you've crossed the line of waiving EPSDT, do you get to broader waivers of EPSDT, for example, in states that want to waive huge amounts of Section 1902 and say that they are pursuing a block grant, which I do fear is somewhere out there over the horizon. But in addition, just the waiver of 19 and 20-year-old EPSDT coverage involves a lot of young adults who need EPSDT comprehensive services. Brain development continues well into young adulthood. For young adults with significant chronic conditions, that 19 and 20-year-old age range is an extremely sensitive time. It's a time also when the nature of new diagnoses, whether they are behavioral health diagnoses or physical health diagnoses, tends to change. So on its own terms, waivers of EPSDT for young adults are problematic. This one is a doozy. Drug testing as part of eligibility determinations, which has been proposed in Wisconsin. As described on this slide, this is problematic on Medicaid grounds. It is also problematic on ADA grounds, that essentially you're denying access to care by denying insurance coverage. And it is extraordinarily problematic on the eligibility policy grounds that I was talking about in terms of documentation requirements. This is so far beyond a documentation requirement, requiring people to pee in a cup in order to get Medicaid in some sort of a county human services setting. That will be an enormous barrier to coverage for people with substance use problems that need treatment. It will be an enormous barrier to coverage for everyone else. waivers of retroactive coverage have been a small part of the Medicaid program for a long time. It is something that the Obama administration did at a small scale. But I think we're now seeing a potential cascade of waivers of retroactive coverage. Retroactive coverage along with NEMT, the non-emergency medical transportation benefit, are vulnerable because they are unfamiliar to people, and they seem like a luxury or Cadillac kind of benefit. But the key point to make with regard to a policy argument around retroactive coverage is that, again, no one else except for Medicaid beneficiaries has the annual redetermination and churn problem. And if you combine waiving retro with a bunch of new documentation requirements and with lockout, it's going to be terribly disruptive to continuity of care. As noted in this slide, hospital associations and nursing home associations can be great allies on the issue of retroactive coverage. I alluded to the similar vulnerability of non-emergency medical transportation. I experienced that myself when I was working at CMS and we were doing waiver negotiations on expansion with the state of Iowa, where the former governor of Iowa, Governor Branstad, personally put his foot down that they were not going to have an NEMT benefit in their expansion. There is an evidence base that shows that transportation is a significant issue for Medicaid beneficiaries. It's worse for lower income than for slightly higher income Medicaid beneficiaries. I'll note that there is some difficult to interpret evidence that shows that there's still significant unmet need for transportation for people who don't have the NEMT benefit, for example, in Iowa. My proposed interpretation of that would be that the NMT benefit itself, even though it provides really life-saving transportation services, is not always reliable in every state. So you've got some people who are describing their frustrations with the NEMT benefit and some people who are saying, I have no way to get to my medical appointments. But there is clear evidence from a multitude of sources that for states that have NEMT, the people who rely on it the most are people with chronic health problems and frequent interactions with the healthcare system. And if those people don't have access, as most Americans don't, to convenient public transportation, don't have either the physical ability or the financial ability to drive themselves, NEMT is all they have. Time limits on Medicaid eligibility. This is, again, a real potential paradigm change in the conceptualization of the Medicaid program. We have states that have proposed both 5-year and 3-year limits. And this really calls an important underlying question about whether Medicaid is going to be a TANF-type program or whether it is going to be what it is now, which is a big health insurance program that's a core part of our healthcare system and covers 70 million people from all walks of life. And I would note that going back to statutory limitations on Medicaid waiver authority, that the statute makes no reference to time limits whatsoever. The statute is not shy when it comes to the temporary nature of other programs. It's literally part of the name of the TANF program. And I am hopeful, although I do not know this, that Kentucky's withdrawal of escalating premiums based on time of enrollment may have something to do with the perception that this was particularly vulnerable legally. I guess we'll find out. So with that, I think we are going to be answering questions as submitted on the participant feedback section on the left of your screen.
Great. Thanks, Elliot. And so, as Elliot mentioned, we will be taking questions on the chat box. We have gotten a few already, and so I'll go ahead and start with some of those. One of the questions, as part of the 101, who submits 1115 waivers to CMS? Is it the legislature? Is it the governor? Does it vary state by state? So, Dee, do you want to start?
Yeah, I'll start, and Elliot, you can add anything that you like or that you think I'm not getting right. It really depends on the state, and we have seen both. In some states, it's starting with the legislature, and it's part of legislation. In other states, the executive branch, the governor is just submitting a request. And then sometimes we're seeing this come in also as part of an amendment to an existing waiver. So that's, and that comes from the executive branch. So it really depends on the state and also how they're going to do this, as an amendment to something that's already out there or a totally new waiver request.
Anything to add there, Elliot?
So the only thing I'm going to add is something scary, which is that Dee described exactly how it is. It has always worked and is supposed to work. But I am concerned that if, for example, and this is not even a waiver, this would be a state plan amendment, if there's a dispute between a legislature and a governor in a state where formally the legislature has the right to submit a waiver, that CMS may mess around on an approval out of deference to a politically friendly governor. That would be inappropriate if that happens, but we may cross that bridge.
Okay, thank you, Elliot. We had another question that was asking what is the official definition of an able-bodied adult in waivers? Is there an official definition? And if so, what would that be? Or have we seen one that was, how was it included in the Kentucky waiver? I'll go to Dee first again.
Okay, well, there's no official definition. That's really a talking point that we're seeing thrown around to kind of create a perception, because a lot of these waivers are combined with language that paints a lot of adults who are getting coverage as people who shouldn't be getting coverage or who are trying to get something for free. So this really is a talking point that's being thrown around, and there's no official definition of it. How a state defines it in their individual waiver request, it's really not who is and isn't able by, it's who does and doesn't the work requirement apply to. So I, in my presentation, talked through a couple of things we usually see, like usually states are saying people who qualify as disabled are not subject to the work requirement, full-time students, medically frail, and it's really tough to figure out how the state's going to define that. A lot of it's vague. But it's not a set definition.
But in the waivers that states are submitting, they are defining who would be required to seek work.
Right.
And so when they define the individuals that would seek work, they are then including a number of exceptions.
Right.
And in some states, there are as many as 14 different exceptions that are out there to try and carve out different groups from that. And so that sort of goes to the point I think both you and Elliot are making, that that a lot of this is a political posturing, that this discussion of able-bodied adults is simply to get across a notion of someone who is lazy and does not want to work.
That's right.
When in fact we know that 80% of the adults on Medicaid currently that are below age 65 are working or have a member of their family that is working.
Right.
And that is a fact that we are seeing as part of the research that has been done. And yet we're still seeing that states seeking these waivers are carving out these different exceptions, which are going to make it much more difficult for individuals who are seeking Medicaid to figure out what box they fit in, and the red tape and bureaucracy that a state is going to face as it tries to enforce some of these work requirements are going to be the very things that end up depriving people of job opportunities in the future, that people are going to lose job opportunities because they're going to have to respond to the red tape of government just to get health care. And that seems to be the whole posturing here.
That's right. And so what you would have a state say is, oh, well, we've got these 14 exemptions. But as you pointed out, Patrick, the paperwork someone's going to have to go through to prove they fall into one of those boxes is going to make a lot of people give up. It is creating a lot of what I refer to as like tail chasing for people who want to get health coverage, and a lot of work on the part of state employees. So, I mean, people should ask questions like, how many people are being hired to manage this program? And the end goal here is to get people to give up and not get coverage, and then kick some people off.
Well, in fact, we did get one question, which is what is the impact of work requirements on state budgets? And with a particular reference to the portion of guidance that doesn't allow states to use federal funds to provide assistance to enrollees in attaining, seeking, or maintaining work. And so has there been any sort of data that has been generated to determine the impact of these work requirements on states?
Well, states are supposed to submit budgets when they send these in, the request in. How good those are, and it usually doesn't pull out like what the administrative cost of this is going to be. And that's something that advocates should try to get a handle on as they're working, as these things start happening. I think, and Elliot, you can jump in here if I'm missing something. I think that in reference to the guidance, this is talking about what the Obama administration had said about work requirements, possibly, but that work requirements had no place in Medicaid. But that's really what the Trump administration is saying is not their position.
Yeah. Well, I think, though, the specific element that the question referenced did get carried over into the new guidance that came out in early January, which is that that guidance said, states, as part of work requirements, we expect you to be coming up with some sort of more affirmative work-related programs, but don't think that you can draw down Medicaid match for things that are like more Department of Labor workforce programs. And I suspect, that it comes out of a fear that if they opened that door, that you could just see states shifting all kinds of currently state-funded programs or slightly federally funded programs into their Medicaid programs, which are mostly federally funded. But the only other thing I'd say in terms of the costs is that there will be a lot of administrative costs, but there will also be, for almost any of these waivers, a major reduction in Medicaid enrollment. So that will save money because you'll have a lot more uninsured people who are not using Medicaid services. That gets into the whole argument, which we've all been making for decades, about what the costs are of having people be uninsured. But even separate from the cost argument, I think it's just it's worthwhile noting that the only projections that we have in terms of enrollment losses are the ones that the states generate themselves. They have their own reasons for projecting them. But if, for example, Kentucky stays as approved, survives litigation, I really think there will be dramatic losses in coverage there.
So one question that we've gotten is whether or not there's any evidence that work requirements have increased Medicaid denials or have led to longer waiting times for people to get Medicaid. And my guess is that since Kentucky is the first state that we're seeing this in, we don't have any evidence of that at this point. Correct?
That's right, but we do have evidence from the TANF program, and there are a number of studies related to that show that the work requirements there are not creating long-term sustained employment for people. They're not creating increases in people actually working. So right now what we have to do, because the work requirements in Medicaid, Kentucky, as Patrick said, is the first, aren't out there, is look at what's happened with some other programs. And yes, enrollment goes down, but long-term sustained employment for people is not going up. So, and also just going back and saying, First of all, this is a health care program. This is health insurance. It's not paying people for anything. It pays doctors, it pays hospitals, it gives people access to health coverage. So, drawing that distinction, I think, is also important. How it is not like TANF, including pointing out where TANF has not worked for people.
That's great. So one of the things that people are interested in is, of course, the lawsuit in Kentucky. In Kentucky, 15 Medicaid enrollees filed suit on January 24th. They filed the suit in U.S. District Court for the District of Columbia, challenging the work requirements that were in the Kentucky waiver, and also seeking an injunction to prevent these requirements from being carried out. And so we have a question about what would be the effect and outcome of the Kentucky lawsuits for work requirements. Do you want to take that, Elliot?
Sure. So, there's a lot of uncertainty because there has been limited litigation in the history of the 1115 program about exactly how this will go. But even starting with litigation in 3 or 4 states, which I think is really pretty likely at a very bare minimum, you could have different jurisdictions ruling on. So I think the first step will be getting an injunction to hold up implementation. And then, as of now, the Kentucky litigation is being pursued in the Washington, D.C. District Court. We'll see how it works out with other states. And one way or another, I think this is likely to be pursued through appeals and, either ending up at the appellate level or maybe even the Supreme Court level.
So, Elliot, in your experience, has there ever been a case of a waiver being overturned or thrown out?
Yes. So there was and not that long ago, a waiver in Arizona that imposed cost sharing beyond statutory limits. And it was challenged. The National Health Law Program was a big part of that. And it went back and forth. It kind of bounced around, and eventually the waiver was effectively withdrawn. But it was both implementation was enjoined, and then that the specific cost sharing was overturned during that process. It's convoluted, and there's actually that specific story of the Arizona cost sharing, but it's really, in terms of Medicaid waiver litigation, it's really the most important example. And the key point is that the federal court there, first of all, challenged a really much more mild, and it challenged and throughout a much more mild waiver in terms of having higher cost sharing. And its reasoning included, well, this isn't really a demonstration, which is a high bar, right? I mean, we're talking about things that are really actively destructive to core tenets of the Medicaid program. And they threw something out saying this is not really going to add to our knowledge about cost sharing. So that particular case makes me optimistic about what the outcome of litigation will be.
Dee, did you have anything to add?
No, I think that's
great. So we had another question that for states that have not expanded Medicaid yet, and where the work requirement is now being used as a bargaining chip in the negotiations of whether or not they move forward with a Medicaid expansion, what is the best strategy for state advocates in terms of advocacy?
Well, I would say, I talked about this a bit at the beginning, it is a tough choice. There is no question about that. And in your state, you need to decide, what's best and what's best for you. But we are asking advocates to keep in mind that it could be a very short-term step forward, and then you could see 2 steps backwards. And I would say, bringing up the points that most people are working, and then asking, how is this going to really help communities? How is this really going to bring jobs to communities? What's really going on here? Try to ask the questions that I outlined in my presentation that really make people who are advocating for this, talk about what they're doing and try to expose the fact that a lot of this is about cutting people off coverage.
Well, and I think that one other point, I think, the first point every advocate should make is how many of the people, the adults on their Medicare program are currently working or have members of their household who are working.
Right.
How many of those adults under age 65 are working? In the vast majority of states, it's well more than half of those Medicaid recipients. And one of the things that we have done in the past here at Families USA is look at who is doing that work. That these are people who are working in the hospitality industry, who are working in the healthcare industry as caregivers, who are working in daycares, people who are working in jobs that don't pay a high wage and are hourly employees who are making less than the poverty level, and point out that those people are working and that to require work requirements is going to make it harder for them to keep their jobs, that it's going to take away their job opportunities, and that they are also going to be creating a bureaucracy within the state that is going to result in people either losing their jobs or losing their health care, and they can't afford to lose one or the other. People need to have both. So I think that there are the basic points for opposing work requirements have to start with the number of people that are currently working, talk about the type of people those are, give them a story, show them the face of people that are working that would be eligible for Medicaid under the Medicaid expansion, and then make the case for how this is forcing them to make a choice between a job and their health care and how they're going to end up losing out. Those are the pushback arguments, I think, that have to be made out there so that you're changing the conversation. The polling that has been done shows that while people overwhelmingly support work requirements just in general, that when you get into the deeper conversation about how it would affect individuals and their job opportunities, that the conversation shifts. And so that's what we have to do in these cases, is think about ways that we can shift this conversation so that it's not about work requirements, it's about job opportunities for people so that they can be healthy and be sustaining members of their own communities. And that's what we need to shift the conversation to. At the same time, I think there is an awareness that in some of these states, legislatures have an overwhelming majority to actually pull something like a work requirement off and pass it within the legislature. I think that doesn't mean that we need to give up our arguments. I think we need to continue to make those arguments with the recognition that there might be an adoption of an expansion with work requirements by the states over our voices. But we need to also think about the longer-term fight, which is if the lawsuit in Kentucky results in the work requirements being pulled, the next step is going to be to go to Congress and make sure Congress passes a law that requires work requirements. So we need advocates in the states to make these cases against work requirements for their own state waivers so that they can build the case and build the support for that long-term fight, which is to fight work requirements when they come back up before Congress. And so I think that we need to understand that from an advocacy side, this has many pieces to it over the long term. The first phase is obviously in fighting these work requirements for waivers, and in the end, what we want to do is make sure that the law that currently exists, which many of us believe does not allow work requirements under the law, remains the law of the land. So I just put that out there for those folks that are looking at Medicaid expansions and having to make the tough choice between coverage for people and work requirements as part of that discussion. And I think for national groups, you will continue to see the national groups push that message out there writ large because the precedent of having work requirements is considered to be so damaging. So I don't know if you have something to add, Dee?
I think that's extremely well said, and I think that the point that you made about how this impacts people who are working and how it's going to be a barrier for them keeping their jobs, continuing working. If someone's working multiple jobs and you don't have a single job that counts up to the minimum for whatever your state's requiring, how much are you going to have to get, and how many employers are you going to have sign stuff? And if you're an independent contractor, how do you verify the number of hours that you've worked? This is really going to be onerous for people who are working. It's going to be a pain for their employers, and it's going to make it harder for them to keep the jobs that they have. What do you do if someone is babysitting for some period of time and some doing pickup jobs that are not standard work, but it is work? And how do you document that? And do you have to get how many signatures for every small thing that you do that is work that's not the work that someone who has a 40-hour job in an office, how they look at it, that when people are doing multiple things to cobble together the work that they're doing, it gets really tough.
And that goes to the point of the new economy, which is, I
Right.
think, another piece of this that people need to understand, that in this new economy, we are moving to a place where there are more entrepreneurial workers. There are fewer workers who have the benefit of a job health care insurance plan, and there are also more people that are working a variety of part-time jobs
Right.
rather than just one full-time job under the new economy. Whether they're an Uber driver or a daycare teacher or whatever, there are a number of different places people work in the new economy, and therefore they don't have health care insurance, and they need to find some place to get it. So those are some of the arguments. I'm afraid we're at the end of the hour, and we had additional questions that we're not going to be able to get to today, but I would like to take this opportunity to thank Dee Mahan and Elliot Fishman for joining us for today's webinar. We will be providing the presentation for people to go and look at, and the other thing is we will be keeping in touch with our colleagues across the board. We know that there's work being done around messaging, around focus groups, and around polling to develop better messaging on this. And so we'll be paying attention to that and following up with folks. So be sure and pay attention to our emails, and we hope to be doing more webinars on this and other topics in the weeks ahead. So stay tuned, and we look forward to speaking to you again. Thanks so much.